Okay, well, hi, my name is Stephanie Nakajima. I was comms director at Healthcare Now for 7 years, and now I'm executive director at MassCare, the Massachusetts campaign for single payer healthcare. So I don't get to see many of you as often as I did before, but so great to see you here at the conference. So we're gonna do just a quick round of intros since there's sort of a manageable number of us here. So name, pronouns if you would like to share them, where you're coming from in the world, and then the prompt today is one thing you really don't like about going to the doctor. And so for me, I would say, oh, I'm in Dorchester, here in Boston, Massachusetts. Any pronouns, I'm non-binary. And the thing I don't like about going to the doctor is that ever since I was a kid, I've been like really panicked about doctors, like in general, and I still sort of have like a panic attack when I go to the doctor. So doctors also love seeing me. Do you want to introduce yourself, Paul?
Yes, Paul Kachai. I live in Gary, Indiana. I'm the chair of Northwest Indiana Medicare for All, and I got some dogs decided to start barking in the background. I live in Gary, Indiana, if I haven't said that already, but I really don't have a problem anymore going to the doctor. My primary care physician is a kid I used to change his diapers. He's the son of my best friend, Alice Bush, who was a organizer for 1199 and was president, and then SEIU organizer for years. So I don't have a problem going to him, and I see a variety of other doctors for different ailments. So I have, in your old age, you don't have a problem going to see doctors. That's all.
So it only gets better. Good to know. Patty?
Hi, Patty Healy, Northampton, Massachusetts, she, her. I'm a retired nurse, and I worry about when I go to my doctor because she's a PCP I love, and she wants to get out of medicine. And she says every time I'm there, and I'm terrified because then I won't have a doctor. It's impossible to get one, honestly.
Totally. I've gone through like 3 PCPs since I've been in Boston. They've all left the practice or done something better with their lives. I don't even know, but yeah, exactly. Martha?
I'm Martha. I'm just recently retired after 40 years at Children's Hospital in Oakland. I'm still an officer finishing out my terms of California Nurses Association and NNU. I do not have a problem going to the doctor, but I have found that since I've retired and transitioning to Medicare, that it's a bit more complicated than I thought it was going to be. So it's not the doctors, it's all the shit around administration and fragmentation of healthcare that makes it like you avoid it. So at least all that pay anyway, especially when, yeah. So
All the stuff Medicare for All would fix. Exactly. Deborah.
So I'm Deborah Berger. I'm one of the presidents of National Nurses United, and I live in Sonoma County, and it's really warm here today, 81 degrees. And so I don't mind going to the doctor, but and since I retired, I was lucky enough to have a Medicare, pension and retiree health, so it made a huge difference. So my copays didn't change, and my premiums haven't changed. So.
And that's definitely a win in this healthcare system, I would say. Heather.
Sorry, trying to get my cursor to work. I'm Heather Stockwell. I use she, her, and they, them pronouns because I am also identify as non-binary or gender non-conforming. And I am in New Hampshire. I'm the healthcare campaign organizer at Rights and Democracy in New Hampshire. And I think those were all the major questions. My least favorite thing, that's a complicated question. I would say right now, the thing that comes to mind the most is being believed. And I generally have a list of things that I'm ready to tell my doctor about. And sometimes when I go over the notes, I am kind of, well, hurt because it's some of the terminology that's used is, it basically says that I wasn't believed when I said the thing that I said. And I won't even get into like a specific thing because there are multitudes of that going on. And that's part of being, I think, a woman. I think that's also just partly too because of autoimmune and sort of like chronic conditions that aren't really visible on the outside. I don't know. Do you want to pick the next person?
Yeah, definitely hear all of that, Heather. And that was something that people brought up a lot in the last session too, when they said their least favorite thing about going to the doctor. So I definitely identify that with that. Don.
Yes, I'm Don McCann, San Juan Capistrano, California, and I'm a former president of PNHP, and probably the incident I like least about my physician is that I had a series of strokes and seizures and went into coma with stroked out and was placed into a hospice for terminal care, and surprised everyone by waking up. And when I woke up with my brain cells washed out, I figured those couple of decades, all that was left there was Medicare for all. Why aren't we doing that? I mean, that's so obvious. You know, I can't see why everyone else doesn't realize the same thing. Anyway, that's, my doctor did let me loose. He dismissed the mortician, so.
That really puts my bad healthcare experiences into perspective. Going to the doctor and not wondering if you're going to be admitted into hospice unnecessarily. My God. All right, Don, you win. Marva.
Hi, my name is Marva Wade. I live in New York City. I'm coming to you from Harlem, USA. I am a retired registered nurse. I know Harlem, USA. I get my own, zip code. I have been retired for maybe 4 or 5 years, and I am certainly still active in NISNA. We are NISNA-NNU. So glad to be in the NNU family recently. So I work with many organizations, PNHP, Labor Campaign for Single Payer. I seem to be a joiner and a worker. I'm your best hope. Old best hope, but just your best hope though. So I'm an OR nurse, and I actually don't have any fear of going to the doctor, except when I was working, I didn't have to have supplemental health care, and I didn't have to, pay any of these other things that I have to pay now. That was an awakening. But my doctors that I had back in the day are still my doctors today. So I guess in some ways I'm fortunate. Thank you.
Wonderful. Thank you, Marva. Tom.
Yeah, Tom Wilson, he, him for pronouns. I live in Chicago, Illinois, and I'm like many of the people here in the group, it seems like I retired about 5 years ago. I was a disability activist and particularly focused on health policy for people with disabilities. And I'm active in the Illinois Single Payer Coalition, and particularly active with the Disability and Long-Term Care Committee within that group. My experiences with healthcare have been fairly good, but I do not like seeing the dentist. It's too often pain involved and the cost is outrageous.
That's great. My husband is Danish, and he in Denmark, when we lived in Denmark for 3 years, there's actually dentists, Danish dentists, who specialize in people who are scared of the dentist. And that's actually like a known phobia in Denmark. It's like being scared of the dentist. Oh, you go to that dentist. So that's the next level for American healthcare once we get, like, you know, the basic stuff down.
Good idea.
Sandy. Yeah, exactly.
Thanks, Stephanie. I certainly chime in with the prior speaker and the prior speakers. I'm a retired bedside nurse, still a member in Quincy, Massachusetts. I'm still an active member of the Massachusetts Nurses Association. I'm most active in Mass Care, together with Stephanie, the Massachusetts Campaign for Single Payer Healthcare, and its local hub, the Social Medicare for All group, as well as the Fund Healthcare, Not Warfare working group of Massachusetts Peace Action and the Labor Campaign for Single Payer. So anyway, for decades, I've been going as a matter of principle to my local community health center, which I consider culturally competent care close to home. And that's the trouble is, I don't know whether it's funding or not, but about every 2 years, I have to break in a new PA or NP as my PCP. And that gets annoying. Great people, hard workers, but I think there's not enough money in the system to pay them what they're worth. I think that's part of it. And I also have required a number of consult specialists for, you name the organ, I get a specialist for it. And they're not in the same system. So trying to get one of these specialists out of network, if you want, that the network as such hasn't affected me. But the fact that trying to get regular reports on my visits to the specialist back into my folder, my file with the PCP and so forth, the fact that we have such a broken up system is really disparaging. I often discuss this, like maybe like we need a VA for all as well as a Medicare for all, to get some breakdown of all of these competing entrepreneurial IT systems that don't talk to each other. I could go on for a lot longer, but I think that's enough for now. Thanks.
Thank you, Sandy. Yep, agree with everything. David?
Yes, thank you. David Loud, he, him, Seattle, Washington. I'm a retired healthcare worker, worked for 45 years in the industry, public sector, private sector, congressional staff. And I've had the good fortune that my medical home since 1972 was Group Health Co-op in Washington State. And several years ago, Group Health was bought by Kaiser. It's no longer a co-op. And I'm still fortunate that I have a very good relationship with great providers. I'm happy about that. I am distressed that the hearing aids I should be having now are prohibitively expensive, and I'm putting it off. And I know I'm at risk for not being able to regain, not being able to save some of my hearing if I put it off much longer. One of my frustrations is that since Group Health was bought by Kaiser, I really have experienced how Kaiser is too big for its britches. And there's a lot of things about the organization of Kaiser in Washington State that are getting more and more sort of remote from hands-on. And also, I've needed eye surgery fairly urgently for several months now, but because of COVID and the impact on OR time availability, I won't be able to get it till May 22nd. It's, putting me through a lot of discomfort and difficulties in the meantime. And I learned recently that the CEO of the National Kaiser, last year, his salary was something in the range of $35 million. And I'm thinking to myself, I don't know what the whole superstructure of Kaiser wastes in terms of executive salaries and that sort of thing. But I'm thinking that if it weren't organized that way as a profiteering for a not-for-profit corporation, that there would be more staffing and more OR time available, and I wouldn't have to wait so damn long for this surgery. So anyway, I'm happy with the docs, but I'm not happy with the system.
Thank you, David. So Bill jumped on, and I just want to share the prompts with you, Bill. We're just introducing ourselves, name, pronouns if you would like to share, your location, and the thing you like least about going to the doctor. Rachel, I think you're next.
Hi, everyone. My name is Rachel Atchison. I'm in Salem, Oregon. I retired a few years ago in California, moved up here. I know no one up here likes that, but it happens. And I'm working with Healthcare for All Oregon now. She, her.
Great, thank you, Rachel.
A bit about the doctor. Sorry, I forgot. It's not too bad, but when I was younger and had to go to the gynecologist, I wasn't a huge fan of that. But my primary doctor's fine. So I'm lucky.
I still hate it. I still hate it. Debbie?
I'm Debbie Schwartz, she, her, in Portland, Oregon, active with Healthcare for All Oregon Action on the board there. And I want to piggyback a little bit on what Heather said. So as a woman with multiple complex, non-visible health conditions, it's challenging to find not just doctors believe you, but doctors who want to treat you. And now it is all the more worse because of somebody with who's immune compromised. With the recent removal of the medical mask mandates, I have to risk my life to go to a doctor. And that should not be.
Yeah, COVID has really thrown everyone, and especially people with immunocompromised states, to a new level, I think. So.
And I also want to apologize about the weird emojis when I first came on. If anybody noticed them, I was looking to see if there was a waving hello emoji and somehow pressed on two other things. So I apologize.
Oh no, do not apologize for emoji. Everybody should be emojiing all the time. Feel free, everybody. Liberally use your emoji functions.
It just didn't make sense from context, but yeah.
That's great. Bill.
You said Bill?
Yes, you're the last
Okay.
one.
Yeah. Live near Kalamazoo, Michigan, active with Michigan for Single Payer Healthcare and Southwest Michigan Democratic Socialists of America. He, him. Nice seeing everybody. And I just went through a cardiac medical event, which required, and everything worked out just fine. But went through a series of making appointments and going to appointments and various tests. And what my wife and I learned is that we have to be very vigilant and follow up with every phone call and every practitioner that I saw, just to make sure things are flowing as they should be and often aren't. That's it. Thank you.
Oh, hope you're doing okay, Bill. Thank you for sharing. All right, we got a good little group going here. Let me jump in. Okay. Okay, so today we're going to talk about racial inequities. What does it mean that they're to have structural and interpersonal racism in the healthcare system, and then also what Medicare for All can and cannot do to alleviate that. So just to start with, I like to always start with, this graphic. Healthcare, it's not just going to the doctor and having access and all of that stuff. Your health is determined by so much more than just your healthcare access, right? Determined by your environment, whether you live next to a large road, whether you have clean drinking water, for example, housing, racism is going to be the major thing we talk about today, but of course, poverty and inequality as well. So the healthcare or access to healthcare is just one piece of the puzzle. And so first, we're going to quickly just talk about how race affects our health. And I think a lot of you are already pretty aware of the awful disparities in our healthcare outcomes, but I'm going to go quickly over it so we can jump onto the next section. But here's just a couple basic slides. Life expectancy in Black and white, for Black and white residents of the US, I'm actually kind of surprised by, this is a Healthcare Now graph, and I have not seen this before. I thought there would be a larger disparity between life expectancy for white and Black people. I know that here in Boston, we have even sometimes a 30-year gap between like the rich zip code and the low income zip code here in just in my neighborhood. But yes, obviously, Black people live less long than white people. Race and maternal mortality rates. This is one of the most truly terrible things about our healthcare system, and is something that is in some ways unique to our healthcare system. I think these disparities do also exist in other countries, but not nearly to the same extent as it does here in the United States. And I think that there's probably a lot of reasons for why mothers are dying in childbirth and from childbirth related causes, more here in the US. But I think it has probably a lot to do with the fact that, when you're don't have access or guaranteed access to insurance, maybe let's say you have Medicaid, like in the South, you get Medicaid, and then once you give birth, you're basically kicked off immediately. And actually a lot of the complications that are going to arise are going to happen in the months after that. And that's sort of like why, because we have really poor primary healthcare, and then of course health insurance, we're going to see a lot more women of color dying, much more so than white people in childbirth and due to childbirth related causes. And this is sort of the same thing with infant mortality rates. Non-Hispanic, Black, and Native Hawaiian and Pacific Islander and American Indian or Alaskan Native babies are much more likely to die than white or Asian babies, and even than Hispanic or Latinx babies. So this is interesting, race and lung cancer. When you look at these statistics, smoking is the #1 known risk factor for lung cancer, and we love to blame health disparities on lifestyle choices. So you might be thinking, oh, the real problem is how many people of like a given race or ethnicity are smoking, but that doesn't actually quite match up. And that's because out of whites and Blacks and Hispanics, the annual incidence is highest among Blacks, but white people smoke more than those, more than Black and Latinx people. So for some reason, Black people are experiencing higher incidence of lung cancer despite smoking prevalence being lower. And then on top of that, when you look at lung cancer treatment, Black people are also less likely to get the treatment they need before it's too late. For example, studies have reported that Black patients are less likely to receive surgical resection than white patients, which likely contributes to data that shows that Black patients have a lower survival for early stage cancer, lung cancer. And looking at some data from a study that examined data from 95 to 99, Black patients were 66% less likely to receive timely and appropriate treatment than white patients. So there's multiple layers of things going on there. Yes. And Marva in the chat says zip codes matter. Zip codes very much do matter, especially here. I mean, at least I know just from here in Massachusetts. So let's talk a little bit about racism and how it drives healthcare inequities. So before we sort of jump into that, let's define some of the terms we're going to use. So what does it mean when we say racism? We're kind of putting forth this definition from Patricia Bedole-Padva, where she defines racism as prejudice plus institutional power. So according to this definition, racism requires 1, racial prejudice, and 2, the social power to codify and enforce this prejudice on an entire society. So that's why, although people of color can certainly be prejudiced against white folks because they have been traditionally excluded from power to restructure society around those prejudices, the idea of reverse racism is really a myth. So racism shows up differently in so many places in our society. And so it's kind of useful to distinguish between the kind that shows up in our public life and the kind that shows up in our personal life. So there's 2 kinds of racism we're going to be looking at today. One is structural racism, which is a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity, identifying dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. So structural racism is not something that a few people or institutions choose to practice. Instead, it's a feature of the social and economic and political systems in which we all exist. And then, of course, individual or interpersonal racism can include face-to-face or covert actions towards a person that express prejudice, hate, or bias based on race. So to pause here for a second, can you give me some examples of structural racism and interpersonal racism? It doesn't have to be healthcare related. We'll get into that later.
Yeah, on the structural side, redlining of housing was really huge here in Chicago.
Oh, I can't see who's talking.
This is Tom.
Oh, hi, Tom. Okay, good. Sorry, could you say that one more time?
Yeah, redlining in housing, which forced the Black community to be, how would I say, live in inferior and crowded housing. Was a structural form of racism.
Yeah, that's a big one. That's a good one. Sandy?
Well, of course, the white supremacy was baked right into the U.S. Constitution. I'm thinking of the Second Amendment, which was designed to empower the slave states to justify their own slave patrols and so forth. And that's carried out all the way down. And of course, an individual personal act of racism would be to shoot a young person in the face if he comes knocking on your door and you don't recognize him, a young Black person, just was in the news. And I think that's a 3rd incident that happened this week of young Black people being shot by white folks. Well, that's enough for now.
Yeah, those are 2 really good examples going all the way back to the founding and then even to today, and both absolutely traumatizing for people. Martha?
Yeah, how public schools are funded, right?
It's a big one. Do you want to elaborate a little bit more on that?
Well, I know that that often it's based on local property taxes. And so where you live, your school might have better funds. It's also based on some of the public schools, survive better with family support. So if you have a wealthier neighborhood where people can spend time, assisting the public schools or whatever, that they're usually, there's more extracurricular activities, those kinds of things. There's all kinds of funding. And I don't actually know much about funding in other states, but I assume it's pretty similar to that kind of thing where it's not universally funded, and different school districts have different funding. And people incorporate smaller school districts in areas like redlined areas, essentially redlining themselves out of other areas of big school districts, suburban schools versus inner city schools. It goes on and on.
Yep. Yeah, that's an interesting, another intersection with racism and and public supports. So Marva.
I think certainly the way that the law works in America, that we have a prison system, even though Blacks are a minority, they certainly populate the prison system in this country. So you can have more criminals of one ethnic group when they are a minority of the ethnic group. And how, people make money from prison. They make things, they work for outside concerns, they get paid nothing. So it's just the new, slavery. It's like put you in jail and put you to work almost for free. So certainly our legal system and the way our laws work are absolutely structural, racism.
Yeah, 100%. You don't see the insane levels of incarceration in other countries that didn't have in-home slavery. Of course, other countries, especially European countries, did have colonies and stuff, but they didn't have a population living that they had actually enslaved within their borders. And you can really see the direct line there from that to what we have today with the incredible mass incarceration crisis. David?
Yes, the exclusion of domestic and farm workers from the Social Security program that began in 1935, and then the exclusion of Blacks from many of the benefits of the GI Bill after World War II.
Yes. Okay. So you guys could probably give this training because I'm going to go over all that stuff too. But just to mention, Bill also says in the chat, structural VA home loans program, post-World War II, hospitals, and then Heather mentions hospitals closing in neighborhoods with more diversity and lower incomes. That's actually a really big one that we haven't really talked about and should probably always be mentioned in this training, because that's one of the many, many ways in which our fractured for-profit healthcare system just really impacts people of color. I'll take Debbie and then we'll move on.
Sorry, I did not realize I was muted. The ACA the court striking down the mandatory Medicaid expansion so that the states that had a disproportionate number of African American people and other people of color on Medicaid were denied access to Medicaid. And then piggybacking onto what somebody said about hospital closures, not controlling hospitals with a global budget that separates capital expenditures so that we can have the new facilities in areas that we need them. And finally, Donald Trump's politicizing the virus, COVID, when he noticed that it was disproportionately killing Black and brown people and disabled people.
Yep, all good ones, all terrible ones. Yeah. Whew. That was a tough time also, just with the tongue flu and all of that from the origin of the virus. I think was awful also on there were so many levels in which it was so awful. So well, you guys again could probably we're going to talk about all this in a second. So here's what we came up with, not as an exhaustive list, but some of the major ones. Slavery and segregation are great examples of structural racism, legal attacks on voting rights, and the war on drugs. And interpersonal would be the stuff that we kind of know and think of as racism, calling someone a racial slur, implicit bias, and microaggressions. So we know that a lot of the time when, people think about racism, they do focus on the interpersonal kind because it's the one that seems easier to control, right? All we have to do is not act racist. Of course, ending interpersonal racism isn't that simple either, in part because of the ways all those prejudices are built into the power structure of our society. So let's take a minute to explore the architecture of that power structure through one particularly significant example, which touches on a lot of the things that you guys have already said. The GI Bill, which promised World War II veterans the opportunity to take advantage of those freedoms that they fought hard to defend. So for a lot of white families, the GI Bill was a game changer. It delivered college tuition, low-cost home loans, and unemployment insurance. Those policies, those three big policies, became the foundation for the white American middle class. Meanwhile, Black veterans and their families struggled to access those benefits. This wasn't an accident. It was built into the design of the program, largely thanks to the efforts of Southern Democrats. Remember, the Democrats, were the party in favor of segregation and Jim Crow at the time. The program, the GI Bill, was administered by the states, not the federal government, so it wouldn't bump up against Jim Crow laws already in place in the South. And we're going to talk about that same thing ended up happening with Medicaid, right? So the program would only be available to vets who were honorably discharged. And at that time, Black soldiers were more likely to be discharged dishonorably. That's like the interpersonal racism and sort of becoming or like being elevated to the level of structural racism there, right? Vets were kicked off the unemployment insurance program if there was any other work available to them, even if it didn't pay subsistence wages. And of course, this was a time where, of course, in capitalism, you can pay anybody you want for any kind of work you want, but it was, there weren't as many protections for minimum wage and that kind of thing, or they wouldn't apply to people of color. And GI benefits, they just depended on institutions and facilities that were already built to exclude Black Americans. So you couldn't take advantage of free college tuition if no university would admit you, or if the few colleges accepting Black students were so desperately under-resourced they couldn't provide adequate services. A sweet home loan guaranteed by the VA also didn't do much to advance your station in life unless you could convince a white-owned bank to give you a loan and a real estate agent who was willing to sell you a house in a middle-class neighborhood. And finally, the creators of the GI Bill relied on interpersonal racism to do some of that work for them, right? They stoked racist sentiments, provided cover to white folks who threw rocks at their new Black neighbors, postmasters who refused to deliver unemployment insurance paperwork to Black vets, and countless other individuals who took personal actions that contributed to a growing sense among Black veterans they shouldn't even try to access their benefits. And so, of course, the result was that white families accumulated wealth through home ownership and the higher wages that they were able to secure based on increased education. Black families were left behind, exacerbating that racial wealth divide. And then we got the birth of the white middle class, delivered to you by the GI Bill. Full house. Some people's personal hell right here. And of course, today, the legacy of that GI Bill is that today that wealth gap persists and probably has gotten even worse. The median wealth for white households is about $187,300, and for Black households, it's just $14,000. That's about 1/10 that of their white counterparts. And as you can see here, Latinx households are, not doing that much better either. So. And then white, so for white folks, that means that even if you voted for Obama, you never used the N-word, you have been benefiting from structural racism your whole life. That can be a tough pill to swallow for working class white people who don't feel particularly privileged in our society. You can be getting screwed by capitalism every day, living paycheck to paycheck, and still you probably have a slightly better shot than a person of color. Having white privilege doesn't mean that you have like a lot of advantages. That's not really what it means, so much as that it means that you don't have some of the additional disadvantages that people of color experience. So, and this is a graphic that Jillian from Healthcare Now made to illustrate white privilege versus, what the oppression looks like from two different angles here. And Tom mentions here, exclusion from some unions had an economic impact. That's probably really, really true, and not something we've investigated very much. So let's take another brainstorm session. What are some ways you see structural and interpersonal racism show up in our healthcare system specifically? A lot of healthcare providers in this room, so there's going to be some good answers.
There's a lack of cultural competence, and there's not enough doctors, providers of all sorts from Black and brown and people of color.
100%. Is that, would you say that's a structural or interpersonal? Ooh, trick question.
Mostly structural.
Yeah, I would also say mostly structural. Sandy?
Yeah, following up a little bit on what Martha said, I think regarding education, I think in terms of where our services cut back, where our institutions, facilities for accessing healthcare cut back. And I know the city of Quincy, which is now about where I live, which is now at least a third people of color, lost its 124-year-old city hospital after it was taken over by a for-profit because they couldn't suck enough insurance reimbursements out of a population that was largely dependent on poorly funded Medicare and Medicaid reimbursements, or at least less funded than wealthier communities. So again, there's an interaction between race and class, if you would, but clearly those communities are suffer the most.
Yep. Thank you, Sandy. So messed up. Marva?
I live in Harlem, as you well know, and I've lived here long enough to have seen so many hospitals in my community close. And unfortunately, the services that they provided were never duplicated in the community. We have a health and hospitals, which is a city system, one of the few in the world, where if you go to the hospital, if you don't know your name, they give you a name and take care of you. But I have gone to so many hospitals that were closing and demonstrated to try to keep them open to no avail. And those hospitals were always in poor communities, very much what Sandy said, that, there seems to be no need to provide healthcare, you know, to certain people being like me.
You know, the hospitals thing is such a hugely overlooked piece of healthcare inequality. Like whenever I hear people talk about healthcare, and maybe that's because I'm in the Massachusetts context, but it's always like, oh, we have 98% of people insured in Massachusetts. Well, meanwhile, hospitals closing in Quincy and Dorchester, you know, all that. I mean, it really just shows you what the whole, you know, system really cares about. And it's definitely not the people of color. So it's just getting little notches, you know, for their cap as legislators to show, oh, we have 98% of people insured. Debbie.
Biases that some doctors have that are just medically inaccurate about differences in pain tolerance among different races, differences in how thick somebody's skin is in different races, a predisposition to assume that people of color who are in pain are drug seeking as opposed to in pain. And that's interpersonal, but there could be better education in med school. In that sense, it's structural. And another thing that would minimize this slightly structurally is patients controlling their own medical records. So if one doctor accuses somebody of being drug seeking when they're really just trying to get an MRI or an X-ray, they can go to another doctor without that next doctor being biased.
Yeah, exactly. And I really appreciate, I think it's hard sometimes to tell where the structural and the interpersonal begin and end because they're self-reinforcing and then they feed into each other. And
Exactly.
Yeah, no, good points. Martha?
Well, because it's a financialized industry now where the entire focus is on profit, and because it's a market where you have to have the ability to pay, it's built in that there's going to be unequal access for anybody who has any kind of disadvantage, not only economic, but transportation disadvantages, housing disadvantages, environmental disadvantages, all of that, you know, piles on and making it structurally unsound. Even the technology, right? And how studies are done for patients and who gets tested and what kind of medications are sold and all of that. Ugh, huge. We lived in a mess up world, as you all know.
No, exactly. And yeah, when you live in exactly a society that is built around benefiting white people to the exclusion of others, then you're going to find all of those inequities around housing and everything that just compounds to create an even worse situation. I'll let David have the last word on this.
Yes, the underrepresentation of people of color in clinical trials, and which, among other things, blocks the development of treatments that may be more specifically valuable for different people of color.
Yeah, definitely. Population groups have, you know, different health weaknesses and strengths. And so, yeah, it's kind of going back to culturally competent care. I mean, 50% of Japanese people have hypertension. And that's something that's been really hard for my doctors to figure out with me, like, why is your blood pressure so high? And it's just actually totally genetic for me. So anyway, moving on. So here's what we came up with. Basically, you guys kind of knocked it out of the park here. Oh, whoops. Lack of access to insurance due to an unemployment, job type, or inability to afford coverage. That's one of the worst things about, I think, the for-profit sort of employment-based health insurance system is that it just replicates the inequities and the racism in the employment sphere. Lack of access to providers or facilities, another structural issue we talked about a lot. Inability to afford healthcare costs, very basic, could be fixed just by Medicare for all. Interpersonally, lack of culturally informed care. That's a really, really big one. An implicit bias among healthcare providers, which we also talked a lot about. And somebody brought up the pain issue. And I saw a very disturbing article or study that came out very recently, last month or so, that showed that even at the end of life, doctors are reluctant to provide Black patients the end of life pain care they need because of these biases that end up and they sort of these researchers decided to study end of life care just to see if these biases would like carry over even when addiction or whatever the concern is isn't a problem anymore, and they found that it still was. So that was very very distressing. I don't have a whole slide on that, but maybe I'll add one for the next time. Okay. Yes, and we talked a little bit about, uninsurance rates and race and structural racism in action here. Of course, these are problems that we all face in a for-profit healthcare system, and but they dramatically and disproportionately impact people of color, right? So looking at who is uninsured in the United States, very much so disproportionately Latinx, actually, American Indians and Native Alaskans, Native Hawaiians and Pacific Islanders next, Black, and then white. And one of the things that I always like to talk about is that in Massachusetts, where I do healthcare now mostly, legislators love to talk about how we have 98% of people covered, but actually when you break it out by race, you see that actually less than 90% of Black and Latinx people are fully insured through the whole year, which means they're experiencing churn. They're probably getting dropped off insurance, then having to find another insurance. They're more insurance unstable, even in the great state of Massachusetts, where we have 98% of people insured. And again, of course, insurance is just one very poor metric of determining what your access to care is. So. Okay, and now for a very short video.
Among high-income countries, universal health care is standard, except here in the United States. Why is that? Here's a reason that you may have never heard before. Our failure to pass a national health plan is largely due to America's history of structural racism. In 1945, Democrats were in control of the House, Senate, and the executive, and President Harry Truman decided to push for national health care. That year, 64% of Americans supported a national health insurance plan. Support in the states' right South, which was heavily Democratic at the time, was even higher than the national average. Seem too good to be true? That's because Truman's proposal would have expanded health coverage through Social Security, which at the time explicitly excluded agricultural and domestic workers. That meant 60% of Black men and 80% of Black women were not eligible for the benefit. However, the push for national health care coincided at a time when challenges to Jim Crow and discriminatory provisions in federal programs like Social Security were also underway. In 1946, Truman established a Civil Rights Committee, which desegregated the military and banned discriminatory hiring practices in the federal government. Southern elites began to link new proposals coming out of Washington with threats to segregation in education, healthcare, and housing. The possibility that a national health plan would desegregate the healthcare system and institute a significant transfer of wealth from whites to Blacks caused Southern support to plummet from 66% in 1945 to only 22% 4 years later. Southern elites were a core constituent of the Democratic Party at the time, and nothing could be passed without them. In 1949, around the time every other wealthy country was moving towards universal health care, the Democratic coalition fractured and Truman's plan in Congress died. In 1964, the NAACP won a landmark Supreme Court case requiring hospitals built with federal funds, which was most of them, to desegregate. A few months later, the Civil Rights Act was passed, reinforcing this mandate. Passage of a true national health plan was still blocked by Southern Democrats in the 60s, since after the Civil Rights Act, this would have meant desegregating the entire healthcare system. So in 1965, the Southern delegation finally came to the table to negotiate the creation of two groundbreaking yet limited healthcare programs: Medicare, which initially covered only seniors, and Medicaid, a state-run program for certain groups of low-income people. The Dixiecrats ensured that these programs were designed as much as possible around the racial hierarchies in the healthcare system. For example, Medicare is split into two parts. Part A, the part that covers hospital care, requires no premium. Medicare Part B, the part that covers physician care outside of a hospital, does require a premium. Why split Medicare into two parts? Part B was designed this way so that physicians' offices in the South could claim that it was a voluntary insurance program, not a direct government payment, and continued to racially segregate their offices and refuse Black patients. And why was Medicaid created as a federally funded but state-administered plan, while Medicare was administered by the federal government? This compromise allowed Southern states to discriminate against low-income people of color in terms of eligibility as well as benefit levels. And this also dramatically slowed the desegregation of nursing homes. While Jim Crow laws no longer exist, the impact of structural racism on our country's healthcare system has been profound. People of color are still overrepresented in states that have poor safety nets and strict Medicaid eligibility requirements. And new waves of immigrants, particularly Latinx, have fallen into these systems of racial inequity created for African Americans. True national health care, like Medicare for All, was blocked by segregationists during the post-war period when the rest of the developed world was establishing healthcare as a right. By the 1970s and 80s, a large healthcare industry and lobby had emerged, making passage of national healthcare more difficult and likely requiring a massive social movement. It's time to atone for this ugly chapter in our history by building that movement and guaranteeing everyone healthcare from cradle to grave.
Any quick thoughts or questions about that video? Sandy?
I think there's a disjoint between fighting for social democratic advances domestically and, for example, the racist dropping of atom bombs on Hiroshima and Nagasaki, for example, the escalation of the American war on Vietnam and its neighbors in Southeast Asia. So I really feel that we need to build a united movement that's going to address, when we have almost $1 trillion in the annual budget of the US dedicated to instruments of repression, military, police, espionage, and so forth and so on. I think we need to balance, have in the back of our mind that the US has, or is racism gone global? And so that's part of the structural racism that we need to deal with.
Really good point, Sandy. Thank you. David?
Yes, one thing that I'm a little surprised that the video didn't include was, on the other side of the ledger, the success that the Medicare bill had in desegregating the hospitals of the South. It was a remarkable development. There's a whole movie about it that I'm forgetting the name right now, but
Power to Heal. Power to Heal.
Thank you. Power to Heal. It's an amazing success story, and it didn't happen from the top down only through that legislation. It happened through a very aggressive organizing campaign on a very short timeline, and it was successful. Desegregated all the hospitals in the South. And that's one example.
And Chicago.
Thank you. Thank you. One example of how Medicare for All can serve us in overcoming racism in healthcare.
Yep, the federal government has power. It has the money to have power. So that's what we always gotta use to fight racism essentially. Is the arm of the federal government. It's an effective tool, at least at the structural level. It's effective, so.
Among
Oops,
high-income
sorry,
countries,
y'all.
universal
Why am I not able to move to the next slide? Okay, here we go. Okay, so that was sort of an example of like the structural part, the structural racism that, we have inherited, that came out of, all the Jim Crow and then the fight for civil rights at the same time that Medicare and Medicaid were being established. So this is more about interpersonal racism, a short clip here.
Some of the misconceptions that exist about Black women as they're seeking healthcare is that we are uneducated.
If I'm not seeing a provider of color, I expect to be treated poorly.
As Black people, we have very unique experiences, especially living within the context of the United States, that ultimately impacts our health and our health outcomes.
When it comes to navigating healthcare as a Black woman, some of the lessons I learned growing up were really an outgrowth of my mother's experience. She had chronic asthma. And so one of the key things she taught me was you have to kind of really articulate your symptoms, say that your pain is a 10, make them take you seriously, because otherwise, a lot of bias comes into your experience.
I was working for an academic medical center, and in one of the departments that I worked in, the environment was really toxic. I was dealing with racism, microaggressions, and I found myself breaking out in chronic hives on a daily basis, to the point that I would sometimes have to leave work and go home. And so I went to see an allergist. She was a very pleasant doctor. She was a white woman as well. And she ran a bunch of tests on me to see what I was allergic to. And the tests, everything came back showing that I wasn't severely allergic to anything. And then when I left the job, the toxic job, the chronic hives stopped happening. So I realized that it was the stress of being in that work environment that was triggering these hives. I remember reflecting on that experience and thinking that if I felt like my doctor as a white woman would understand the experience of dealing with racism at work and microaggressions, that I might have naturally shared with her what was going on at work. But because I didn't think she would relate or understand, it just never came up.
When it comes to the birth of my first child, that experience was pretty tough. Even in trying to ask questions and seek out information, I was repeatedly marginalized, told, oh, you don't need to know that. You don't need to worry about that. I think I would have benefited from more of an informational approach, more of these are your options, and more of we're respectful of, the kind of care that you would like.
We curated a provider network of providers of color. That's not to say that Black patients should only be seen by Black doctors, but we wanted to make it easier for Black women to find those types of providers. And that's why we built our platform. It felt important for them to also have a community where they can ask other Black women, like, hey, I got diagnosed with breast cancer, and these are the options that my doctor shared with me. Has anyone else gone through this? What will I look like once I undergo this procedure? And so we brought all of those components into one platform to support Black women as it relates to anything related to healthcare, whether it's finding providers, finding information, or finding community to navigate a health journey.
My vision for Health and IQ is that we become the first stop for all Black women and women of color when they have any question about their health or want to seek information for their health. Ultimately, we want to impact all 50 million of these women in this country. And so we're just at the beginning of that journey and are excited to continue.
Sorry, I'm trying to figure out how to just minimize this now. Why can't I minimize it?
some of the misconceptions.
Okay. So that was, you know, when I think about, when I take a step back and I look at these two videos and I think about the things that, you know, Medicare for All could fix about the healthcare system. So all that crazy structural racism stuff, I think, you know, a large part of that could be fixed by just Medicare for All, giving everybody the same exact access, no matter where you live, your income, color, all that stuff, right? And then when I think about like the interpersonal racism, which is the way that, you know, people experience going to the doctor and what they experience when they get there, that's, I don't know if Medicare for All is by itself in any way going to fix that. And I honestly do not know what is going to fix that. I think that requires a much bigger level of investment in well, I think one of the ways in which Medicare for All could fix it, but it would have to be very intentional, would be actually ensuring that there's money in the system for recruiting doctors from communities of color and that kind of thing. But like, you know, the woman in this video was saying, it can't be that, you know, Black people only go to Black doctors or whatever. You know, we have to actually apprehend the racism that exists among providers as well. So I just think about these two videos when I think about the benefits of Medicare for All, and then also like the limitations of what a Medicare for All system can do for the problem of racism as it exists in all its forms in the healthcare system. Any quick thoughts or questions about that before we move on? Heather?
Yeah, I mean, it was just something that I think that the video illustrated pretty well, and I was thinking about it before. And I mean, I think Deb also brought this up in that last session, that there are, I mean, I live in New Hampshire, it's 91% white. And I hear people say really stupid things all the time, like, well, you know, Black people are more prone to like all of these things. And so this is why we can't afford a Medicare for All system. And I'll come back with other things and stuff. And like,
Look,
and
we
have
can't afford the Medicare for All system because of Black people. Do people say that?
Yeah, we're also very Republican here. So people look at us like we're purple or blue because we did go to Biden. But the fact of the matter is that New Hampshire's local government is all Republican controlled, and we are fighting so hard every single day just to maintain any kind of protections or rights. It's really can be really ugly. And so it's just something that I've been thinking about, because even people with disabilities or chronic conditions are not, you know, assumed all these other things that you shared your own thing about hypertension. And I think that's it. You know, I think there are some things we could do, like we could say, hey, everybody gets offered the same bucket of care for each condition. I mean, that could help with some of it, but it is like, you know, I think you said it, it's going to take a lot more sort of training or talking to people reasonably, and not just reacting and flying off the handle like, oh, you're just, I don't want to talk to you because now you're a racist. And like, I recognize as a white person that part of my job is to talk to people who hold these interpersonal beliefs, right? I don't know. It's just something that's been going through my mind.
Yeah, all important things. It's crazy how the myths persist about like sort of we have such like bad, you know, habits in the US, and that's why our healthcare costs so much money, and it's like very kind of like coded dog whistly as well. And it's yeah, it's actually just to, this is so sort of off the topic, but Philip Morris actually, as sort of a rehabilitation campaign, did a study showing that that people who smoke spend less healthcare resources because they die earlier. And that makes so much sense. It's like, if you die at like 95, you've survived like 3 cancers and 2 heart attacks. And, you know, I mean, you're going to expend more and more resources the more you hang on So, I mean, people of color are actually subsidizing, a lot of them are subsidizing Social Security and Medicare because a lot of them die before 65 and then they work all their lives, they put into the system and then they don't get it. So that's all BS. I mean, that's crazy BS, like on a statistical and a moral level, on like every level. So, Marva.
You know, there's so many things that are so broken, you know, in this country, and it's really difficult being a person of color and having, it's like the sister who broke out in hives, you know, on her job. It is every day such a struggle to just put one foot in front of the other and hope you're going in the right direction. And I share with all of you, the thing that gives me hope and keeps me in this fight is what I see in front of me, that I am not alone in wanting something different and knowing that something different is possible, because there are so many of us that see something different. We all have our baggage. You know, I was born in the segregated South, right on the back of the bus, naming and claiming, can't try on the dress in a store. But even though I've lived in New York for a long time, I tell you, we all carry the same baggage, and everything that we were, it is a struggle every day not to succumb, you know, to it. So it's people like you, it's people that I've been seeing in this workshop and having this as the reason that we are wanting healthcare for all, is that for all means for all, not for a group or a race, or that it's for all. So that's what keeps me here. And in my heart, I thank all of you for being in the fight, because I kind of feel like you're fighting for me. And I thank you for that. That's kind of wishy-washy, but sorry.
Of course, Marva, thank you for all of that. Yes, absolutely. And that's why I think just the conference is a great space to come and get replenished a little bit when we're out there and we're doing all of our work and we're talking to people who think we shouldn't have healthcare because whatever bad reason. And so it's so nice to come together and reaffirm each other's values and all of that. So thank you all for being here. Appreciate that. Sandy.
Yeah, I just want to thank Marva for putting that in context. And I also want to reflect on one thing you said a minute ago, Stephanie, that yes, we can get a just financing system in place, but it doesn't automatically mean we're going to eliminate racism and all of the disparities that affect health. But it will raise things to a level where they won't be able to use the excuse that that we can't afford to do this or we can't afford to do that. And we also need affirmatively to rebuild the services, rebuild the facilities, rebuild the access to healthcare that have been destroyed, particularly since this, the last 40 years of neoliberal market orientation and the corporatization of healthcare. So we got our job cut out for us, even after we win Medicare for all.
Absolutely. The fight never ends. Thank you, Sandy. So my moderator has let me know that as usual, I've completely failed to keep us on time. So I'm going to try to get through the last 2 slides real quick. So, now talking about Medicare for all, we've talked a lot about in the Medicare for all and what it can and can't do. And now just to talk about the Medicare for all movement. So Medicare for all, #SoWhite. A lot of the faces we see in the media advocating for single payer, including our comrade Bernie, are white. So are the members of a lot of single issue Medicare for all groups. Surely you've noticed this. And the question is this an accurate picture of our movement? And the answer is no. Media tends to just ignore the contributions of people of color to our movement. When polled, people of color are more likely to support Medicare for all. Legislators in POC districts are more likely to support Medicare for all legislation. For the 100th and for the 116th Congress, which I think is 2 Congresses ago now, but anyway, it's about the same still. Only about 22% of reps in the Congress were representing majority POC districts. But when you look at the Medicare for All bill, more than half of the co-sponsors of that bill were those representing majority POC districts. So, of the 118 districts, represented by Democrats who were not co-sponsoring the Medicare for All bill, and I'm sorry I don't have a visualization for this, but the districts where we probably have the most organizing work to do in these districts that are Democrats, but they're not on the Medicare for All bill, they are 3/4 majority white. So really the people we need to be organizing is not like we get like our panties in a wad about like, oh, we need to organize people of color, but actually people of color are organizing themselves and they're organizing for Medicare for All. We need to make sure we're also organizing white people because white people are the ones who are holding up the bill. So just to give a couple more, statistics about this, in some states, the racial gap is really stark. So in Illinois, every single major POC district had their rep on the Medicare for All bill, but there were 8 majority white districts that were Democrat and they were not on the Medicare for All bill. So who needs to be organized in Illinois? Same for New York. Every majority POC district had a Medicare for All supporter in Congress, but 7 majority white districts who were Democrats were not on the bill. So what are our takeaways? We need to amplify the important work of our people of color Medicare for All activists. And our movement should be visibly led by the people most impacted by our issues. And white people are the ones who really need to be organized in support of Medicare for All. And overcoming racial bias is going to be a big part of that, especially this idea of categories of undeserving people who shouldn't be in the Medicare for All system and not. And now, especially I would say these days, we're getting like a lot of immigrant, like, Latinx, undeserving, documented, undocumented immigrants, right? So I'm sorry again, we're now 1 minute over, or maybe like 6 minutes over, I'm not sure. What is the one thing you'll take away from this training that you will use in the future?
Well, I'd like to see the slides, to use them in various ways.
I can give them to you right now.
I think, Stephanie, the takeaway is that nothing in this country ever changes, except extremely slowly. So the longer and the more persistent you are, the better chance you have for change, and not to give up. I mean, I've been doing this for so long, I've forgotten, but that, you don't give up because change is possible. And you just have to stay in the fight until you get what you want, and bring younger people in to fill the backfill like you, Steph.
Amazing. Thank you. Great takeaway.
I'll say something, having been a latecomer and missed almost everything, but having come on and heard the comments in this session, and capped off by Marva's just amazing wisdom and experience. It's very inspiring to see a lot of people and a lot of old friends and comrades in this fight. And my takeaway is I'm inspired by that. I've been practicing in a community health center for the last 40 years, in a safety net setting, just seeing all the racial inequities and really banging on that as a priority while participating in the single payer movement. And to see now the single payer movement move forward on 2 fronts, on racial equity, while at the same time gaining universal coverage is so inspiring, and just increases my resolve to participate and keep engaged in this struggle. So I want to thank you all also for your involvement and the inspiration you provide.
Thank you, Arthur. And I think, I think the recording, or it is being recorded. So if you missed, anybody in here who missed the beginning or whatever, you'll be able to see in the recording. And yes, I think the 2 tracks, I actually don't think we get Medicare for All without racial equity. You can't, this healthcare system was built, as we saw in the video, through a racist gatekeeping of resources for whites and to prevent, people of color from getting them. And the way we're going to unlock that is by getting Medicare for all finally, right? So we don't get one without the other. So. And yes, I think I'll probably just I'll send like everybody who came to this with like links and stuff. So if you want the video or you want the slides, then I can put them all in an email for you guys. Sorry, Debbie, I think you were going to say something. Do you want to have the last word?
Just going to ask for the first video, but it sounds like you're already doing that.
Yes, I'll send all the links and everything to y'all.
Thank you.
Thank you guys so much. Thank you for staying all the way through the whole day of Healthcare Now conference. Have a great weekend.
Thank you.
Bye-bye.